Okay, this is a PowerPoint that I put together just to, okay, this is a slideshow that I put together specifically myself just to kind of give you an idea of some of the medications. I think throughout the ATI book and our textbook, I think it gets kind of confusing with some of the medications. And so if I can help at all, I will, trying to just make this a little bit easier for you. I'm trying to make my slides move. Okay, so I'm going to start with tocolytics first. So what is a tocolytic? And now you can't see my face. I don't know where it went to. Oh well, okay. So let's go back to our tocolytics. So here's our tocolytics. You will need to know those and what those tocolytics do. Tocolytics, toco means labor, lytic means to stop. What stops contractions? Well, a couple things. Couple of the big ones that we're going to talk about is mac sulfate. What magnesium does, it relaxes the smooth muscle. So it stops preterm labor. So if you got a mom that comes in preterm labor, we also use mac sulfate for hypertension too, because it relaxes the smooth muscle inside the blood vessels to allow them to dilate instead of staying so constricted. So we use mac sulfate in both preterm labor and we use it in preeclampsia. But the biggest side effects that we see with this is a couple of things that we need to tell our moms is the minute that you start to give your magnesium, they're going to feel this really warm flush come over their body. And that's normal. And it's an irritant to their veins, so it may be a little bit irritant to the veins and maybe a little painful. It does cause CNS depression, so we want to look for those loss of our deep tendon reflexes and our decrease in urinary output, and especially our decrease in our respiratory system. If we start seeing decreased DTRs and decreased respiratory system below 12, we need to stop our MAG and get some MAG levels. The next one's terbutaline. We're going to call that breathine. That is our brand name. This is our generic name. So we're going to learn it by terbutaline. This medication is given sub-Q, and it stops preterm labors. Sometimes this can be given PO too, and these moms will go home on it. Sometimes if a mom comes into preterm labor, maybe she was in preterm labor from a urinary tract infection, we've resolved the urinary tract infection, and we've put her on breathing to stop those contractions. So she may go home on that too, but we use that to stop those contractions. Nifurtine is a calcium channel blocker, and it stops those contractions by entering that smooth muscle. But biggest thing here, we cannot give it, if we're going to give it if MAG is going, cannot give both of those medications because they're both smooth, they both relax that smooth muscle. They may potentiate each other. Indocin is the other thing that we can give. The only thing that we don't like to do is Indocin would be our last resort to stop labor. We don't really use it a lot. It's probably the most dangerous because it blocks the production of prostaglandins, and it does stop labor. But the problem with this one is it can cause premature closing of that ductus arteriosus inside the fetus. And if it closes that inside the fetus can't breathe, and it doesn't get oxygen. So the fetus would demise. So we don't like to use that one unless it's at all we got to. So what are some things we're going to do to mature the lungs? So we got a baby that's 32 weeks, and we know that mom's imminent. She's going to deliver, and we've got to do something to help those lungs mature. Betamethasone is a steroid that we're going to give. It helps produce surfactant in the lungs of the baby. We're going to give them, we're going to give this IM, and we're going to give it 2 doses, 24 hours apart. Now, not a lot of adverse side effects with this, but just usually moms are going to feel pretty good. Everything's going to go pretty good. If it's been longer than a week and you go back into labor again, sometimes they will give this again to just make sure those lungs are mature. But that is betamethasone. Now we're going to ripen the cervix. These are prostaglandins. These are going to make you go into labor. These are going to make that cervix do something. So, dinoprostone is going to ripen that cervix. It's going to induce that labor. It's going to start uterine contractions. So it's going to make that do what it needs to do. It's going to start the process of going into labor. Cytotec or misoprostol. Misoprostol is what you're going to need to know it by. It's going to induce labor. It's going to cause uterine contractions. It's going to cause all kinds of things. So sometimes if a mom had a missed abortion and the baby died inside mom about 10, 12 weeks, they will give mom misoprostol. They will give her tablets, or they can give this, if we're inducing labor, we'll usually give it in a suppository. This is also a suppository. But if we're trying to make mom go into labor and expel that demised fetus, we will give her the misoprostol, and then it makes her go into labor and she'll expel that fetus. So we usually do that to do that. Now, these two drugs we're not going to give, though, if they've had previous C-sections or uterine surgery, because they're going to start uterine contractions and they're going to start making them pretty strong. Now, other things that we can use is Pitocin. We can use that for induction of labor, or we can use that to help augment labor. So the difference between an induction is where mom comes in and mom's got nothing going. So we induce her. And these drugs back here we use to induce mom, get things going. This one can also be used for augmentation. So let's say that we have a mom that comes in and she's 7 centimeters, but now she's stalled. She's not doing anything. So we can add Pitocin to that to make those contractions get a little bit better. Hemorrhage medicines. So hemorrhage medicines, we can use oxytocin. Again, we can use that one. We can use methyljovine. That one we're going to give IM, and that's usually the second drug that we're going to use. The biggest thing about methyljovine is we do not give it if mom is hypertensive, because it does cause hypertension. So we do not do that in those patients. But it will help with uterine atony and tighten up that uterus to make it clamp down. So oxytocin, methyljovine, misoprostol is also a uterine stimulant, misoprostol. So we're going to give that oral, vaginally, rectally. A lot of times we will give it rectally. If mom is hemorrhaging, we will give it rectally. It works very, very fast. It contracts that uterus down. We can give Carbapost. That's also a uterine stimulant, and it can contract that body down, and we can give that IM. All of these will be in the hemorrhage box. And we can give something called TXA, tranexamic acid, and it's an antifibrinolytic. So it stops that fibrin action from creating, it stops that and works by improving that blood clotting. It makes that blood clot. So it stops that lysis of that clotting factor. Now, it's recommended that we give TXA if they have postpartum hemorrhage. That's within 3 hours after birth. It's going to work better during that time frame. So know all of these. Infections, ampicillin, clindamycin, and Gent. All of those are things that we're going to use if mom has an infection. Gentamicin is ototoxic and nephrotoxic, so we want to make sure we know their kidney function and make sure we're talking to them about that. Opioids, again, the opioids that we've kind of already talked about is, as far as their epidural, they're going to get fentanyl. We can give them during labor, we can give them Demerol, which is meperidine. We can give them Bufanol, Stadol, and now Nalbuphine, which is Nubane. So know those. These are all pain relievers that we're going to use after, and I think we've already seen those back in our other section. We've already talked about these, so I'm not going to go into those again. GI meds, it's not uncommon for your moms to get Colace, which is a stool softener. We just need to make sure that they take it with a full glass of water. And magnesium, which is like milk of magnesia, that's a laxative. It's just going to help them go to the bathroom, or it's going to help with GERD. Maalox, it's also for indigestion, heartburn. Simethicone, which is Mylicon, that can sometimes be help with like gas pains, things like that. And baby drugs, every baby is going to get erythromycin, Hep B, and vitamin K. We don't call it, we don't call it vitamin K. Hang on, from current slide. Let me go back to my baby medicines. Darn it. Get to my baby meds. Okay, get to the baby medicines. Okay, so here's our baby medicines. Erythromycin, Hep B, and vitamin K. Phenotidine. That just helps with clotting. Now, we do not give the phenotidine and the hepatitis B in the same leg. They will be in opposite legs. The erythromycin ointment will be given in the eyes. Now, all three of these drugs will be given within an hour after delivery. B and vitamin K are IM injections into the vastus lateralis. So, that is it. That's all your baby drugs.